से आए हुए हैं डॉक्टर मुरली वर्मा और डॉक्टर MP सिंह सर को कि कृपया आकर के चेयरपर्सन की भूमिका निभाएं। मैं आज के इस हम लोग के साइंटिफिक सेशन की शुरुआत के लिए ओपनिंग बैट्समैन के तौर पर हमारे UPOA के कर्मठ सचिव डॉक्टर संतोष सिंह सर को आमंत्रित करता हूं कि वो आए और अपना वक्तव्य दें।
Hello, good afternoon everybody. It's a great initiative by PRAYAGRAJ Orthopedic Association and Dr. Manishi and the team of PRAYAGRAJ Orthopedic Association, Dr. KD, Dr. Kapil, Dr. Nikunj and all the members. So it is my privilege and honor to be here as a frontline batsman on the inauguration of second Platescon. Can I have slide, please? So my topic is the clavicle fracture. Actually, I'm talking about the surgical intervention because it is a Platescon, and it is not necessary that every fracture should be fixed in the clavicle because the majority of us know the main treatment of clavicle fracture is the conservative treatment. So I am discussing about where it should be done and what should be the precautions and what are the type and methods of different methods for the play. So it is all you know is 5% of all fracture, and about the half of the fracture of the shoulder are the clavicle fracture, and majority are the mid shaft. So as you know, commonly they are in the middle and basically subdivided into the non-displaced and multi-fragmentary fractures. This is the Robinson and Edinburgh classification. It is a majority of for the purpose of academics. So for the benefit of the audience, I'm going with the so many historical perspective points are there, but these are not true. So conservatively treated displaced fracture heal as malunions. We know the majority of the fractures are treated by the conservative means. So what the problem will occur when we go for the non-operative treatment, as there is a shortening and angulation, and there is a callus bump. So in majority of the cases, we cannot accept this condition as there is a shortening, deformity, and maybe the non-union or malunion with the pain and in physical impairment in majority of the cases where they required some different functions of the arm and shoulder. So on the review of literature, we have taken so many studies and got the finding that there is a 50% cases of the poor osmosis of the contour, and there is a callus bump when they are treated with the conservative means. And in the 30% cases, there are the discomfort or chronic pain is there, and the 20% cases have unsatisfied patient. They have a non-union, malunion, shortening, limb shoulder mobility, and loss of strength. So these are after reviewing the literature available on the net. So Mackey et al. Have studied the cases, and they have found the result as displaced mid-shaft clavicle fracture can cause significant persistent disability even if they heal uneventfully. So, and they another Hurst et al. In 2010, they have studied on the 53 patient, and they uh, uh, conclude that the fixation has more satisfied with better dash score than the non-operative treatment. So the non-operative treatment indications are if displacement is less than 12 to 15 mm. If it is more, go for the operative treatment as well. And angulation is less than 10 degree. Surgery is still controversial. Where we to do, where would not to do. These are the some debatable topics, but the interest is now increasing due to the demand of patient, new techniques, and new implants. So what are the absolute indication for the clavicle fixation? The first one is the open fracture. Second is the neurological deficit, and in some cases of the floating shoulder, not in the all cases of floating shoulder as well. What are the relative indication for the acute fractures? There are so many relative indications are there. The first one is the widely displaced fracture if above the 15 displacement is there. The second one is in the polytrauma cases. And the third one is the displaced distal third clavicle fracture is there. And fourth in some type of the floating shoulder cases. The fifth relative indication is, sorry. Fifth is in cases of the seizure disorder, if patient have that is, and for the cosmetic reason, majority of the time we have this type of relative indication. And in a sports person, when we need a complete arc of the shoulder joint and we need a complete length of the clavicle, then it is very important. And if patient want early return to the work. So these are the relative indication for the fracture fixations. So what are the operative treatment? There are two types of plating and nailing, as you know very well. And these are the implants which are used for the fixation. In the plates, we have different options, LCP, Recon LCP, anatomical LCP, and the majority used for the nailing are the TENS, and some specialized clavicle nails are available also in the. So in IM nailing, some stiff pins can be used, TENS, and some specialized nail, but here it is a Platescon, so I am more concerned on the plating of the clavicle. So they may be the straight or reconstruction, and if the reconstruction plates have to be molded according to the clavicle, then there may be the implant become weak and combi hole deformation may be there. So there is a different plates are available on the LCPs. These are two positions. It is depend upon the choice of position which you want to be. The first one is either you can put the superior position on the anterior position. There are the different advantages of both the positions in the cases. Sorry, there is some technical problem in the remote. Yes. So you have to mold according to this if you have to put the plate anteriorly. So anterior inferior plate position is better. Why? There is a longer screw, mechanically better. If you put plate on the front, then there is a 12 mm screws, and if you anterior to the posterior, then the screw will be bigger and purchase will be more. So, and no risk of plexus injury in the anterior-inferior plate position. Implant not prominent under the soft tissues, so less need for the implant removal. Locking compression plate has an advantage of the less exposure, and so these are the better. And the MIPO, we can use the LCP as a MIPO plates, so they have a less exposure of the fracture side, and sometimes may use the double plating also. Uh, the locking compression plate had the advantage of the biologically friendly. They have a better mechanics. Screw head is less prominent, easier MIPO technique, and less screws or shorter plate can be used in these cases. But the implant removal can be difficult, and it is no panacea in all the cases. So this is not 100% safe in all the cases. Treatment of distal third clavicle fracture, if there is non-operative treatment, about one-third fail to unite. And where is the inoperative treatment? 100% of fracture healed within 6 to 10 weeks. So lateral third of the clavicle fracture should be considered for the operative fixation as well. So what are the different treatment option for the lateral end of clavicle? The first one is the banding of clavicle to coracoid process with stitches as usual in birth. The second technique is the Bosworth screw technique. We can use the LCP T plates or hook plate, and in late cases, excision with the stabilization of the coracoclavicular ligament should be done. But it is not, as you know, surgery has its own complications. So in these cases also, there are some complications as infection, non-union, and refracture after the plate removal. And same as in IM nailing, the complication are poor reduction, telescoping of comminuted fracture, migration, fatigue, or bending. Recent data complication are with IM fixation, the non-union are the about 10%, but in plate fixation, non-union are the 3.2%. So in reference to the non-union, the plating has less than the IM nailing. What are the contraindication for the operation? If there is active infection in the operative area, prior soft tissue irradiation in operative area, burns over fracture site, debilitating medical condition, high risk of non-compliance, elderly patient with a sedentary lifestyle. So these are the relative contraindication for the fixation of the clavicle. When we comparison to the plating versus intramedullary nailing, there is no difference in the functional outcome, healing time, and non-union is approximately same plus minus. When we go for the evidence-based medicine, multi-center prospective randomized clinical trial done on 132 patients. Non-operative group have 34 males and operative group 53 males, and they have done the fixation with the same technique, oblique incision, recon plate, superior plate position, and 3 screw proximal and distal, and they outcome the measures on the 6, 12, 24 weeks and constant Murley score and with the DAS score. So they will find the constant Murley score is better in the plate fixation cases than the non-operative cases, and DAS score is also good in the plate fixation than the non-operative group. So the result are generally range of motions are same, but there are some minor differences in the fracture union and all that. So the patient satisfaction according to the Canadian Orthopedic Trauma Society, plating group has a 4 times more satisfied patients, 52 patients satisfied with the appearance in plating group, and cosmetically droopy shoulder of greater cosmetic concern than scar. So the data support primary fixation of completely displaced mid-shaft clavicle fracture in active adult. So what should be the take-home message? There is evidence that operative treatment is best for the displaced fracture. The indication for TENS is restricted to simple fracture as the type 1 selected type B, and in young and active patients with displaced fracture, surgical treatment should be considered seriously. So what should be our current approach? Intramedullary fixation in simple displaced fracture with or without inferior butterfly piece, and plate fixation in displaced segmental fracture and non-union and malunion cases if required. So on the conclusion, non-operative management remains the standard of care for minimally displaced fracture. All conservatively treated displaced fracture heal as malunion. Non-union rate in conservatively treated displaced fracture is more than 15%, and shortening is associated with a higher non-union and unsatisfactory result. Thank you, sir.
We can take the question answer at the end of the session. Go ahead. By the time you are going to have the next session, next lecture. Hello. Any questions from Dr. Santosh? Okay, we can go ahead now. The next speaker is I will request Dr. Unmesh Chakravarti to have his presentation.
Live now? Okay. Good afternoon, everybody, and thank you so much. Can I have the presentation, please? So, plating, we all know it's a very versatile way of fixing things. The challenge which remains is basically regarding the robustness of the fixation, because we are so very much confident when we're doing a nail that we can make the patient mobilize or weight bear easily. So I will be just quickly taking up a few cases of non-union which have been managed by plating. So as time permits, we'll just pick up a few of the cases. Okay. So non-union itself is a great challenge, and each non-union is peculiar and has its own problems and issues. So what we are looking at is how to augment the stability. We have to look at the biomechanical realignment, because we now understand that biomechanical alignment itself is a major cause of failure. Bone grafting has to be done because these are often cases with poor biology. So these are the things we'll be just quickly covering in the cases. So closed fracture humerus, 40-year-old male treated somewhere with plating. Initial X-ray fixation is pretty good, and there are no signs of infection. And gradually, as the patient kept on mobilizing, it progressed. And you can see a lot of osteolysis, massive osteolysis. Looks as if there is infection. Clinically, or even the history did not suggest of any infection. The lab markers were all normal. So again, the question that remains is that how to fix it. We have a massive, massive bone loss out there, and just some proximal and some distal end of the bone which is left for fixation. So looking to the principles of managing it was basically to get the stability right and take care of the bone loss. So the entire cavity was cleared up, all the implants were removed, deep cultures were taken, and the entire cavity was packed up with cancellous bones, and a large, broad LCP was used. So keeping in mind that the narrow plate which was put previously, and humerus is known for very high torsional forces, so broad plate can be often used in our Indian conditions, and we mostly do not use that, thinking that our humerus, the Indian humerus, is thin. And that's how the things progressed from over the months of healing. So stability should be something which we must focus on when we are using plates, even in primary fixations or in case of non-unions, because the versatility that a plate gives gets often negated because if we have not maintained the biomechanics rightly and the device fails because our initial poor stability of the reduction and the overall construct. Another case of plate fixation of proximal humerus. Varus, which is a very common culprit of failure of most of the fractures, and proximal humerus is no exception. So there's a lot of bone loss, and she's a 60-year-old female. And if you see that the CT scan, that still some head is there. So rather than jumping into a replacement, we planned for conserving the natural humeral head. That was the axial sections, and there are sectors of the humeral head which still has a lot of intact, healthy, natural bone left. So again, the strategy remained same, to get the biomechanics right and get the valgus right, and there was a large cavity defect. So after debridement and plate removal in C-arm, we can see there's a huge gap, and clinically there's a big gap. So my common preference is a thick tricortical piece of bone from the iliac crest, which can easily fill up that gap and also act like a good internal buttress. So that's where the graft went, and we tried to correct the varus angulation and the preliminary fixation, which was further augmented using sutures, because these sutures again add on to the stability. So the cuff outside, the plate in the middle, and the graft inside was the total construct. And that's how the fracture progressed gradually over the months. Another case of plate fixation failure, distal femur fixed somewhere else. Probably the patient mobilized too early, and gradually the plates started backing out, the screws started failing, and the fracture was in kind of a non-union. So there was no evident history or clinical findings suggestive of infections. So the entire construct, the plate, everything was removed. Deep cultures were taken from the screws, and there was a medial augmentation done with a longer, larger lateral plate, and grafts were put on the medial side. So that's how the construct was, to get the realignment right, get another buttress and the graft. So in all these cases, we are increasing the stability by using a more robust construct and again taking care of the biology, and this medial plate which added on and gave a lot of stability. Instantly the patient came for plate removal, elective plate removal, and that was the kind of remodeling the entire femur had undergone. Polytrauma case, 20-year-old male. He had a high impact injury, open comminuted fracture of the femur, and we had laceration over the knee, right over the patella with the patellar fracture, and over the shaft of the femur. So initial stabilization was done and fixator was applied, debridement was done, all the segments of avascular bones were removed, and we had put antibiotic cement beads to take care of the infection. Once the wound had settled down a bit, we removed the X-fix and the temporary spanning with the plate so that we could mobilize the knee. The patient was discharged and was asked to come over after 4 to 6 weeks once the tissues were better so that gap reconstruction could be done. But this patient was doing well and he felt that he could move around, so he was lost in follow-up. Once he came back after a few months, that was the condition of the plate. It was bent. So again, these plates, however robust they are all prone to these varus drifts and varus failures. So now we had a bigger problem because this plate has already given way and patient had a narrow canal. So it was not a very good case for getting a thin nail. So we planned to do a dual fixation, and here we took the help of a plastic surgeon who did a vascularized fibula in this case. And this entire vascularized fibula was put in, it was stabilized with the small plate. The purpose of the small plate was just to hold on to the fibula. It was not meant to add on to the stability. You can see the broken screws of the previous plate also, which could not be extracted, and a longer plate going right up to the lesser trochanter. And lucky for us and lucky for the patient, it progressed well for healing, and that was the kind of result that we got. Finally, one of the cases where there was it was an open fracture and had a very bad soft tissue condition. You can see the soft tissue shadows on the X-ray really swollen up. So debridement was done and an X-fix was done for the soft tissues to settle down. So once the soft tissue had become better, I chose to do a mepoplating. A wrong decision on the very beginning because the fracture pattern was not meant for this kind of a fixation. And that's how the thing progressed to fail. And it was almost 1.5 years till the sequence of events progressed. So once this had occurred and the patient was told now we needed a stronger load-bearing device, so he was advised nailing. So we took him up for nailing and freshened the edges up. The nail was put in, distally locked, but still we can see the kind of gap which still persists. So compression was achieved using a compression device, and a small plate was used to add on to the compression and to act as a additional derotational device. So with the nail in situ, the incision was already there because we had removed the plate, so everything was exposed. So we just did the nailing, used a compression device and fixed the plate and added bone graft to it. So that was the kind of initial picture, which luckily progressed to heal in this fashion. So the points which I basically would just like to highlight is that bone grafting in various forms is a must for building up the bone loss, adding on to the stability and biology. Since it's a non-union case that we are discussing, so it becomes one of the mainstays. And it really not only has a biological role, but it adds on to the stability if done in the proper technique. And augmented stability improves the biomechanics and protects the graft. The graft needs to be stressed, needs to be loaded, and it needs to be protected from resorption. And these augmentation plates are something which we should always keep in mind when we are dealing with non-unions, which are those fractures which will be more difficult to deal with as they will take more time to heal. And once we have these augmentation devices, we can be more confident that we can mobilize these patients early. Thank you.
Kindly stick with the time. Any question by the time can be asked to Dr. Unmesh?
Good evening to all of you. First of all, thanks to all the organizers, especially Dr. Kiri Tripathi and Dr. Manishi Bansal for inviting me here. And I am thankful to you, and I'm always interested in coming to Allahabad, as this is my uh, college, my city, and my mentor is sitting over here, Professor N. Verma. I'm always blessed by him. Thank you, sir. Thank you very much. And thank you. Can I have my presentation? Okay. I would like to focus something on indications and techniques of fixation of four-part fracture of the proximal humerus. Proximal humerus, managing proximal humerus, comminuted proximal humerus, it's a very challenging and very decision making. We have to take very decision. Ultimately, the patient coming to us, he want good results. He doesn't want whether you want to fix a plate or you remove the head or whatever you do hemi or you do total or reverse arthroplasty. So sometimes it is very deciding. You have to make planning how to deal with this comminuted, especially four-part fractures. What are the treatment options? Something proximal humerus fractures are extremely common injuries, and one of the two osteoporotic fractures. Proximal humerus fractures account for 7% of all fractures and 80% of all humeral fractures. Above the age 65 years, proximal humerus fractures are the second most frequent extremity fractures. And when we talk of anatomy, greatest range of motion of any articulation in the body, shallow glenoid fossa, that is only 25% of the humeral head. Major contribution to the stability is by soft tissue composed of muscles, capsules, and ligaments. And proximal humerus is retroverted 35 to 40 degrees relative to epicondylar axis. No. Any problem? Some. So there should be no hesitations whenever we are planning for a fixation of proximal four-part fractures. Okay. Stop. They're stopping. I think there's some problem. Can you? So when we talk of anatomy, we should not have any hesitations before going for a surgery of proximal part 4 fracture fixation. We should always go through anatomy. Whether you have so much experience, sometimes we get stuck in many of the cases. So this is some anatomical view of anterior view. This is posterior view. I'm not going to the details. The blood supply. Why I'm talking about these things? Because they all play a very important role in prognosis and further results of your fixation for this fracture. And the deforming muscle forces on the osseous fragment, that is greater tuberosity, is displaced by supraspinatus and external rotators, and lesser tuberosity is displaced by subscapularis, humeral shaft displaced by pectoralis major, and deltoid insertion causes abduction of proximal fragment. Mechanism of injury. Most common is fall on an outstretched upper extremity from an standing height. Younger present falling in a high energy trauma. Less common with excessive shoulder abduction, direct trauma, electric shock, scissors. This is how. This is a common mechanism for low energy proximal humerus fracture in elderly patients. Upper you can see the followed by 4-part valgus impacted fracture. The proximal humerus can be fractured as a consequence of 3 main loading modes: compressive loading load of the glenoid on the humeral head, bending forces at the surgical neck, tension forces of the rotator cuff at the greater and lesser tuberosities. Clinical evaluation: patient is must. Patient typically presents with an upper extremity held closely to the chest by contralateral hand. Pain, swelling, tenderness, ecchymosis may or not be present. Neurovascular examination is essential. Classification: we follow Codman's, Neer's, AO or OTA classification. Neer's classification, most commonly used classification is Neer's classification, useful in guiding treatment based on 4-part anatomy of proximal humerus, humeral head, greater and lesser tuberosities, and proximal shaft. Skipping. Criteria for displacement: greater than 1 centimeter of separation or apart, or angulation of 45 degrees angulation. And change it. Change नहीं हो रही है, please. हाँ. These are various parts: anatomical neck, surgical neck, lesser tuberosity, fracture dislocation. Sometimes why I'm focusing on anatomy part also, because sometimes when you are going to operate on per op, you find a greater difficulty in just restoring the anatomy of the bone while fixation. This is AO classification. Now, why we are focusing more on classification? Because nowadays it is an era of that is documentation. So we must follow proper classification. Radiology. X-ray APN view of shoulder in plane of scapula. X-ray. I know most of the in most of the cities we have a facility of CT scan, MRI, and 3D CT available. But at resident point of view, we must know how to take a good proper X-ray. We must know to tell the technicians to take a proper X-ray before going for CT evaluation, or sometimes we get a good X-ray done with proper positioning of the patient and proper way, like gracious view of the shoulder. We'll have initial assessment of the fracture pattern. That is gracious view. We don't go into the details. APO shoulder in plane of scapula. Next, this is Neer's lateral view of the shoulder. Initial level, at the resident level, it is must. We should know of the basics of the radiological views, how to take an X-ray to get in good view of the fragments, proximal frame. Next, this is an axillary view. These are very important views in proximal part humerus fractures. Next slide, please. CT scan. The advent of 3D CT scan construction has helped to reduce the degree of inter and intra-observer error. It is quite useful. And most of the cases, it is must also for proper fixation. A much clearer picture of the injury, allowing better preoperative planning. Management, that is operative, non-operative. Non-operative, stable, undisplaced, minimally displaced patient, not fit for surgery. Most of the fractures we face 4-part fractures that are elderly patients. So they are having so much of comorbidities. So we have to just took a judgment whether to operate or not operate, and what best can we do for that. Elderly patients with low functional demand and contraindication, displaced fracture with loss of bony contact. Non-operative, immobilization of the arm to the chest using simple collar and cuff sling, replaced or well-proved shoulder immobilization at 2 weeks, passive range of motion, exercises, and proper post-operative rehabilitation should be followed, whether you are going non-operative or operative patients, operative method. At 3 or 4 weeks, radiographs are taken, gentle assistive exercises, pulley elevation, external rotation with a stick extension are begin. 6 weeks, rapid progression to terminal stretches and light resistive exercises, they are started. Operative management. Indications: patient's age, functional status, ability to tolerate, post-operative rehabilitation, fracture pattern, displacement, associated injuries, remaining vascular supply to the articular fragment, and bone quality. This is very important in type 4 fractures. Very, very important decision making. Two surgical approaches, that is commonly deltopectoral, deltoid splitting approach. As you know, deltopectoral approach quite familiar to everybody. Next, that is soft. Like, and deltoid splitting, be careful about axillary nerve in this approach. Next, osteosynthesis by lock-in plate. Indications: AO, type B bifocal, type C anatomical. Contraindications: head splitting fractures, impression fractures that involve more than 40% of articular surfaces. This is an absolute contraindication to philos in these cases where the impression fracture that involves more 40% of the articular surfaces. Humeral head preservation may be possible with locked plate fixation and supplemented with local bone graft or bone graft substitute. The plate should be positioned directly on the middle of the lateral cortex and approximately 8 mm distal to the superior aspect of the greater tuberosity. This is a very important point. While doing part 4 fractures, advantage of using a strut fibular graft with locking plate. I often use fibular strut in proximal part 4 fractures. Proximal humerus are commonly encountered in elderly patients. Surgical treatment demonstrates high complication rates, including varus, construct collapse, and screw cutout. Fibular strut graft augmentation is helpful in the prevention of early collapse and screw cutout. And get an CT done, 3D CT done, and decide whether you need to have a fibula in this case or not. Or apart with stud graft, you can put cancellous graft also. Most of the cases where the patient doesn't want that, he wants to remove his head. He wants no. I want to preserve this head with plate. This is how you take the fibula. This is a post-operative X-ray of the fibula with fibular graft. Type 4 fracture. I don't have a CT. I missed the CT. There was a fracture dislocation. Next, it's with fibula. It is quite helpful in these type of cases. Part 4 fractures and osteoporotic fractures. You are applying proximal plate, fibular strut. It's quite helpful. Next, this is another X-ray. Yes, these are few X-rays of fibular strut grafts in type 4 fractures. Predictors of post-traumatic humeral head ischemia, that is metaphyseal extension of more than 8 mm, disrupted medial hinge, basic fracture morphology, head split component, more than 20% head involvement, angular head displacement of more than 45 degree, tuberosity displacement of 10 mm, more than 10 mm, and glenohumeral dislocation. These are the predictors of post-traumatic ischemia. Prognosis should be explained to the patient in these type of cases. Next. So apart from this, this is something different from plates. Plates. Prosthetic replacement is a good treatment option in osteoporotic patients. Where you don't have an option, you should always ask the patient that fixation or preservation is not possible in these cases. So, an arthroplasty of the shoulder is not an easy thing. So you should very limited indications of arthroplasty: four-part fractures, fracture dislocation, head split fractures with more than 40% articular surface involvement, anatomical fractures, and dislocation present for more than 6 months. Don't ever try fixation for older fractures. For fixation, go for arthroplasty, shoulder arthroplasty in that cases. These are pictures: reverse shoulder, hemiarthroplasty in shoulder. Tinger et al. Showed that cortex thickness is an index of proximal humerus bone density. A mean index of less than 4 mm is an indication for an arthroplasty as opposed to osteosynthesis. These are options of arthroplasty. Hemi, total, reverse. Classical approach, deltopectoral, anterolateral approach is also used, and chances of dislocation is less in previous. Landmarks: coracoid, the lighthouse of the glenoid; biceps tendon, the highway to the glenoid, whether going for arthroplasty or fixation. These two landmarks are very important. Important principles, that is deltopectoral approach, allowing preservation of deltoid, restoration of humeral length, retroversion, and secure fixation to the tuberosities. Indications: elderly patients more than 75 of age, pre-existing large rotator cuff tears. Contraindications: young active patients, except in exceptional salvage situations like bone tumors, infection, and axillary involvement. So these are the absolute contraindications. What Neer says about arthroplasty: when the articular surface of glenoid is good, the results of hemiarthroplasty are similar to those of TSA, where on the glenoid has not been a problem if the articular surface was good at the time of surgery and glenohumeral motion was re-established. These are the difference between total and hemi, easy, and total and or reverse, something technically demanding, difficult in comparison to hemi. So these are, thank you everybody for patient listening. I want to focus on something else. Recently I have been given an opportunity to be an editor of Journal of Bone and Joint Disease. So this is my request. We are working hard on this journal, and this is so recently we have launched our new issue, and we are working on the pattern of Indian Journal of Orthopedics. Our secretary of IOA is sitting, Dr. Naveen Thakkar. We are Journal of JBJD. We are working on same pattern, sir, and soon it will be indexed. We are in the process of indexing. This is my request to all the youngsters. They can send their papers, presentations in with a new vision. Next. Oh, just it's over. We have changed our publishing agency. Now it is Walter and Clover. Just two more slides. Thank you, Medno. And indexing of the journal according to our future aims, and we are in process of that. So many of the people, youngsters, are in hesitation that does we submit our articles in this or not. So without any hesitations, you can upload your submissions in this. We need to have at least in coming years, we'll have a good citation of an impact factor of our journal. I'm working on that. Target. Next. Okay. This is our indexing, current indexing of our journal. And we are working on this advertisement of journal also. What we need to have valuable support for achieving this target. Thank you. Thank you, everybody. And my team and myself and our editorial board is working very hard on this journal. Thank you very much. Thank you. Thank you.
Thank you, Dr. Park.
Thank you.
Best wishes for your new venture. Hopefully things are going to flourish in the coming future.
Thank you, sir.
Either Dr. Chandan Kumar is available here? If not, yeah. Uh, any question will you like to ask from the speakers? Dr. Unmesh, Dr. Santosh, and Dr. Pal? Can you please come in the front? Yes.
Myself, Surimani Devedi. My question to Dr. Unmesh. Dr. Unmesh, you have presented very well. You have shown a case of humerus fracture with lot of osteolysis. Fixation was done with narrow DCP. Later on, you fixed it with broad LCP. So, was it the difference of broad and narrow plate, or stable fixation with locked plate and unstable fixation with unlocked plate?
So your question is very pertinent and you have already answered it. So it's a combination of stability. The idea is not about the broad or narrow. If possible, it should be broad. If not possible, it should be as long as possible, because the fracture construct has now changed. The fracture which we are dealing with initially in the primary situation was a simpler form. Now we put a large void. So a broader, longer plate adds very much to the torsional forces. So a long plate, a broad plate, getting the axis in slight valgus, and then augmenting with the biology of the bone graft. It's a combination, just not the broad plate alone. But yes, we should keep in mind that broad is very much feasible in our Indian anatomy, especially in males, and we should always have it in the armamentarium, because sometimes we land up where we think we can put a broad, but unfortunately we don't have a narrow plate. Yeah.
I want to ask another question also. In the case of tibia locked nail, you fixed it with another added, augmented it with the small fragment or narrow LCP also for rotational stability. So locked nail is giving already rotational stability. If you have compressed the fracture side and if you allow dynamization also for later compression with weight bearing, so what was need of adding another plate for derotation?
Okay. So the plate was not alone for derotation. Again, the principles in the primary fracture of the nail and in a revision scenario when we are dealing with non-unions are slightly different. Normally, if there's a transverse fracture or an oblique fracture in the primary condition, usually the fragment spikes, they interdigitate and they give you additional stability with the bolts. Now, if you see that case, it was kind of a oligotrophic or kind of a non-union. There was callus, and that fracture is absolutely transverse. And what I had done was, after putting the nail, a compression device was used there to give absolute compression at the fracture site. Now, once a compression device is used to get a absolute compression at the fracture site, even if you do a static fixation with the nail, it will not retain that absolute compression. So that plate was basically to maintain that absolute compression at the fracture site, while the nail was the main device which was taking care of the weight bearing. So the two devices were basically augmenting each other. The nail was meant for a stable fixation on which he could walk, and that plate was just to maintain that absolute compression which I was giving at the fracture site, because it's a case for non-union. The principles will be slightly different from a primary fracture.
Dr. Rajendranath from Kanpur. There was long plate, all around the plate there was a lot of osteolysis.
Yes, sir.
In your humerus case, first case. So did you think about any metallic reaction in this regard?
Most likely it was a metallic reaction, because
I have
all
seen,
the
such cases.
yes.
Or one or two.
Yes.
So what action should be taken for this?
So-
if you consider that the problem is because of metallic reaction. How to proceed?
So I think the literature that we get about these metallosis, they're about the body is reacting to the the metal that is being put. But I think when we are dealing with these Indian devices, sometimes the metallurgy is not good, and even the screw and plate of different companies with different metals can cause all these kind of anionic reactions. The plate that I used was a titanium plate for the revision case. But the important thing was to debride. It was an Indian stainless steel implant. But I'm not saying that Indian stainless steel implants
My
are
question
bad.
is-
I'm not saying that.
My
Yeah.
question is, what is the reaction for the surgeon to forbid this the occurrence of these things? Poor metal, poor metal. How to prevent it?
So I think like any alval case or like the metallosis we deal in joints, it has to be a radical debridement, remove all the reactive tissue, the granulation tissue, all the membranes.
No, the metallic problem,
You, I think,
metallic component,
so,
how to
so
proceed?
if the patient gives a history of some nickel allergy, some females give some history of allergies around their earrings or some metal, so then we should go for titanium. And we should go for more bio-inert materials as much as possible and standardized implants. I think that is the only way. Take a good history that if they have some allergies and reactions around their metal rings or earrings or nose rings, if that is the case, then we have to counsel them that they can have some allergy to nickel or other components and go for a more bio-inert implant, a standardized bio-inert implant.
Any question from Dr. Pal or Dr. Santosh? No question. Already explained everything. Thank you very much.
Thank you, sir. Thank you, sir.
Now I will request our respected chairpersons to kindly give the momentous to our speakers. Dr. Unmesh, please stay back. Dr. Unmesh, please come to the stage. I will request our chairperson to please stay on the stage, sir. Respected chairpersons, please stay back. Please stay. Dr. Sudhir, please. Dr. Sudhir Kumar, sir, please. So we are going to start our next session. I will request our chairperson for the next session, Professor D.C. Srivastav. Dr. Tribhuvan Singh and Dr. Anuj Gupta. I'm sorry. It's the second session is I request Professor A.N. Verma, sir, Dr. D.K. Srivastav, Dr. S.K. Pandey, Dr. Kaushal Agrawal. For this session, I request Dr. Naveen Thakkar, Since there is some delay in the flight and schedules are a bit changing, we are merging the second and third session. I will request Dr. Anup Agarwal to kindly come and give his talk. Neeraj, please load the talk of Dr. Anup Agarwal. Meanwhile, Dr. Naveen is preparing. Dr. Anup is also our candidate for Vice President this year from UP. So I will request all of you to kindly have a maximum support to Dr. Anup Agarwal.
So thank you, Team Allahabad, for giving me this opportunity. And I'll be speaking on head radius fracture, how to get it right. My concentration would be mainly on doing the head radius plating. Okay, sorry for all these glitches. I think so. The learning outcome would be to when to use which approach, how to do the plating, and how to avoid the complication while doing the plating. So I'll start with this simple case example. A young male of 44 years of age, history of injury to right elbow in RTA, 5 years, 5 days old, there are no comorbidities. On examination, there was no bruising. There was just a tenderness over the head of the radius. So this is the most remarkable clinical sign. Once you have an elbow injury, you should always try to elicit the tenderness over the head radius and look at the medial side of elbow for any bruising or anything. So this is the X-ray. X-ray looks almost normal. So we suspected that because since there was tenderness, we suspected that there was probably some injury. We got a CT done and it was an impacted fracture of neck of the radius. So it is just by looking at the clinical sign, you can very well diagnose that probably patient had an head radius. The second telltale sign is that the patient will not be able to do a complete extension. There would be just 10 to 15 degrees sort of extension, tenderness over the head radius, some ecchymosis on the medial side. Probably you're looking for fracture of head of the radius. Always do a CT scan and you will find. So, is there a role of really conservative management? Yes, all type 1 fractures, type 2 fracture where there is less than 1/3 of the radius is involved and there is no mechanical block. When I say no mechanical block, how to check? Are you going to check when the patient had pain? No. Give some local anesthesia or short anesthesia and then check the rotation. And if you find there is no rotational block, and less than 1/3 of the head of the radius is involved, then that is a patient, that is a candidate where you can manage them with a conservative management. What should be the protocol of conservative management? 3 weeks plaster slab, and thereafter start range of movement exercise, no loading over the elbow. If you go beyond 3 weeks of plaster slab, patient is bound to get stiffness. So no more than 3 weeks. So then what are the indications for open reduction and internal fixation? All type 2 with mechanical block of motion with more than 1/3 of articular surface with either displacement, depression, or there is a capitular articular lesion, or along with a proximal ulnar fracture, or with MCL injury, or injury to distal RUJ, and some of type 3 fractures which are reconstructible. So these are the indication where you will do some kind of fixation for head of the radius. So I'll skip this classification. Probably everybody knows it well. When do you do an excision of the head radius? Very common questions, and there are no confusion in this regard, that if a small fragment less than 25% and blocking the motion and you don't want to fix, that is an indication where you should remove. If the entire head is comminuted and minded, all the ligaments are intact, that is, there is no axial, varus, valgus, or posterior instability. If you have any instability or any ligament injury, whatever the amount of combination of the head of the radius, never ever do a primary excision of head of the radius. And patient does not have any associated elbow injury. So now I'll have another case example. 25 years female, had an RTA to left elbow. The no comorbidity, 2 days old, important VIP patient. So as I said, these are the telltale sign where you will look for fracture of the head radius. Got an X-ray done. It's a clear-cut fracture of head of the radius 2 or 3 part. How am I going to approach? So first and foremost, that what should be the approach to this patient? Most common is the lateral coccus approach, and how you do it, that you go between Anconius and FCU, ECU. I think this pointer is not working. So you go in between this. This is a totally avascular. This is an avascular plane. As soon as you reach there, split it, and directly you reach the capsule like this. Now you have to make an incision over the capsule, and their head of radius is there. Now there's certain precautions which you need to take once you're incising the capsule. Never ever go anterior to the midline, and keep the lateral collateral ligament intact. So never go more proximally when you are incising the capsule. Otherwise, you might injure the lateral collateral ligament. That is a word about how you incise the capsule. Once you have incised the capsule, you have the head radius, and now how to fix it. There are many plates which are available. These are typical synthesis plates which are available. They are slightly heavy. So you can use maxillofacial plates, easily available, or you can use some of the headless screws which are also easily available. These are the headless screw, usually type 1, some of the type 2, or you can just put 1 or 2 screw and then add on the plate to support the whole construct. Now, where should we put up the plate? The most important question, because if you have put in the plate in wrong direction at the wrong place, then your supination, pronation, it will abut onto the radioulnar joint. So how you check is that you keep the arm in mid-prone position, make a mark that is called A mark, that is in the neutral position. Then you fully supinate, and from A to anterior two-third, that is the area, and then you fully pronate the posterior half. So this is the whole area, posterior half and anterior two-third from the neutral position. That is the area where you should put up the plate. Whenever you are fixing the plate, just put one screw at the shaft and again recheck the full supination and pronation, that it is not obstructing your full supination and pronation. Now, the next important thing, the most dreaded complication while you have a plate fixation of the head radius, that you might injure the part of the posterior interosseous nerve. And that is very thin nerve. If you have it, then recoveries are really difficult. So how to do that is, you completely pronate the forearm. As you pronate the forearm, you could see that whole of the supinator along with the PIN goes anteriorly. So it goes out of the field of surgical area. That is one important thing. So always, while you are operating, always keep it completely pronated. What else you should do? Whenever you are dissecting near the annular ligament, I'm sorry, this pointer, yes. This is the area. Whenever you are dissecting in this region, never ever go anterior to the midline and never try to go more distally to the head and the neck of the radius. Because again, what happens? This is the area. So what happens? This is the area where your assistance is trying to put a Homan or something anteriorly. And there he retracts along with the supinator, he puts a traction injury to PIN. So always be careful whenever you are putting your retraction anteriorly. So just anything is small, a little bit of retraction, and then you reconstruct the head of the radius. So these are 2-3 very, very important and crucial points which you should always remember while you are operating. So now you have exposed the head of the radius, you know where to put the plate, you know how to avoid the injury. Now it is a time to fix the head of the radius. So reduce the head of the radius, put simple K-wire, do a temporary fixation, check it, and then fix it with your plate. Again, I'll repeat, whenever you're putting up a plate, just put single screw, check for the rotation. If it is not obstructing, complete your fixation. Closure is very simple. Everything falls back. You have to repair back the capsule and annular ligament, and rest of the things fall back to its position. It's very simple beyond that. This is the per-op picture of the same patient. You can see it's being fixed, and this is post-op. I'm so sorry, it goes very slow. This is 4-month post-op. This is the clinical result of the same patient. Now, there's another case example just to elaborate on one more important point. A young girl of 21 years doing MBBS had injury to left elbow. This is the CT picture of the same lady. And this is how we opened, and we found that whole of the head of radius almost was completely destroyed and lying anterolaterally. Now, this is what I wanted to mention. If whole of the head of the radius is fractured, none of the part of the head of the radius is attached to the shaft. You can take out this whole fragment, reconstruct here, put temporarily K-wire, check the reduction, put it back, and then fix like this. You can always do that. There is no worry about avian or any sort of complication. You can very well do that. Very well evidenced in literature about this sort of methodology of fixing the head of the radius. This is the post-op par-op picture of the same lady, post-op, and this is the clinical result. So the final pointers about plate fixation is head radius. It's a complex bony and soft tissue injury. It may lead to unstable elbow if not properly treated. You need to maintain the length of the radius also. Good reduction and rigid stabilization of fracture is very, very necessary, because early range of movement you need to start once you have done a fixation. Always, always repair the soft tissue. If you have fixed the head of the radius, and if you haven't checked the stability of lateral collateral ligament, medial collateral ligament, then probably you will fall back. Since there is already a talk about the terrible triad, I have not tried to touch that aspect. Beware of interosseous nerve while you're retracting or operating, because if you have it, then you have it. Patient will have the limb like this for quite a long time, and most of the time recovery doesn't happen. Remain in safe zone, and early range of motion is the key to success. Thank you. So we'll have question right now or later?
We have your question right now. Any questions from Dr. Agarwal?
Please, sir. See, there is not much of a difference between Kaplan's and Cocker's approach, except the plane through which you go. So if it is more anteriorly, so that's where I'm coming. So if you have a situation like terrible triad, where you have a coronoid also fracture and you want to do it from the anterior coronoid also, then Kaplan's is okay. Otherwise, Cocker's is a very simple, for a simple head radius fracture where you want to do a fixation, it's good enough.
This side, Dr. D.C. Srivastava.
Sir.
First case, you showed that there is a compression fracture at the neck of the radius. And you said you must go for a CT in all cases. What is your protocol in this? Why you see the all cases in the CT?
Sir, we are living in a medico-legal era, number one. On X-ray, if I'm not able to diagnose or see the fracture line, I will never be able to tell my patient that you have a fracture, you need a plaster for 3 weeks. So my first thing is that clinically I have to suspect that this patient has a fracture of the radius, and there are two telltale signs that you have a tenderness over the head of the radius on rotation, and there is lack of complete extension, last 10 to 15 degree. And third might be that you have some ecchymosis on the medial side. If you have any of these three, then your first
Anyway,
suspicion would be head
just a minute.
radius.
As far my experience is concerned, large number of cases do not develop these symptoms. Number one, this is not a hard and fast protocol until as you have got an aggressive axial fall. You will not develop the ecchymosis. You will not develop the restriction of motion. There might be some tenderness while you are going for the supination and pronation. And most of the cases of radial head do not require any CT. They require only X-ray. And only patient has to be kept in the CC sling, not in the plaster. If there is a soft tissue injury and there is significant tenderness, that is the one indication where you can go for the plaster. That is not the protocol of 3 weeks. You check it every week. If the things recover in a week or two, gradually go for the exercises rather than waiting for 3 weeks unnecessarily. This is the way I have treated more than hundreds of compression fracture, if I am true. And I don't think that I have applied more than 10% plaster in the cases of compression fracture. And this is not the protocols given in the book also. So taking the things in such a manner that you go for the CT for every compression fracture, in my opinion and my experience as for my study in literature, goes against it. This is what I have to say.
So you may be right. I'm not contradicting your experience, but this is what I have to say regarding undisplaced fracture head of the radius, and that is the protocol we have been following.
Dr. Agarwal,
Yes, sir.
I think, great. Please go ahead and call the next speaker.
Thank you, sir.
Now I will request Dr. Naveen Thakkar to please come and give his talk.
Yes. Good afternoon, everybody. We are thankful to PRAYAGRAJ Orthopedic Association and Platescon and UP Orthopedic Association for inviting and honoring here. I am going to share with you. First, I will be showing you a case and we'll have an interactive part. Then I will show you the technique which has changed my practice with the value addition, which may help you to change your practice. Not working, yeah. चेंजर लगाओ तुम्हारा हाँ हुआ चालू हुआ हो गया चालू. This was the last visit. Still it is not working here. आपका लगा दो ना, आप वाला मेरे में लगा दो. This was the last visit here just before 1 month. This is also not working here. लगाया? Not moving ahead. यहाँ कंट्रोल नहीं है ना, सबसे बड़ा प्रॉब्लम है. ओके, नजदीक आना पड़ रहा है. नहीं अभी नहीं चल रहा है. इट टेक्स कमांड वेरी लेट. चलो मैं वहां कर करता हूं प्रेजेंट. दैट इज बेटर. आपका कंट्रोल नहीं चल रहा है गुरु. नहीं चल रहा है. मेरा वाला लगा है. मेरा वाला क्यों निकाल दिया बेटा तुमने? तुम्हारा वाला कहाँ है? इसकी जगह पर तुम्हारा वाला लगा दे. दोनों लगा के रख. Okay, we'll be learning together. This was the patient, male 52 years, operated in 2016. Surgeon had done Anders nailing, a flexible nailing. What will you do now, sir? Now the patient has come to you.
This is the case of.
Can you make the mic on? Okay.
Yeah. Firstly, this appear to be going to non-union and remove the nail and give the compression plating.
Okay.
And with one nail is also broken.
Nail is
Yes,
broken. So
yes,
you have
sir.
to do a broken nail removal and the compression plating, what he has said.
With bone graft one.
With bone graft. The same thing surgeon has done. Removal of nails, open reduction, locking plate and bone graft, uneventful. Only complaint now was odd feeling, heaviness, tingling, numbness off and on. This was the thing. So patient went to the same surgeon. He tried for removal of plate but failed due to cold welding. So just went to a second surgeon. You can see it's an anterolateral. If you see, it's an anterolateral plating. If you see. And surgeon, this is fantastically united fracture. But second surgeon also tried, but could not remove the plate. What you have been done? First trial failed, second trial, second surgeon failed. Patient has a pain and problem, odd, tingling, numbness, that's why. When the patient, when there is something in the head of the patient, Right. You're right. Absolutely right. You're absolutely right. So first thing is explain the patient that removal of implant is not required. But suppose it has been taken by the surgeon. Now, you're right. Absolutely.
For mental satisfaction, try to remove the plate.
Okay. So again, that surgeon has tried, but what has happened? Now the story starts. Explain to the patient that not removable, and further try of removal may damage the patient shifted to the room. Right? But the story starts now. What is the next? Patient wants to. Very good. But how? What is your solution?
Sir,
I will go. I will go back. I will go back. It is anterolateral, right?
so now plate is to be applied on posterior surface.
On the posterior surface.
Maybe. Better or anterior. Posterior or anterior.
Posterior or anterior surface. How?
Anterolateral, it is already there. That
Yes.
cannot be removed.
Yes. Or
Non-locking.
you will try to remove.
No. Non-locking screws can be removed because we may have some space for the next plate and screw. Little or few screws.
Few screws you will try to remove.
Non-locking, unlocked screws.
Yes.
Two screws are unlocked.
The screws which are near to the
Yes,
fracture
yes,
site. These
yeah.
are the non-locking screws.
Yes.
Others are locking screws. Right.
That cannot be removed. We can leave that. And from another side, from her plate can be applied easily. Leaving the plate initially applied, we can apply either on anterior surface or on posterior.
How anterior surface you will go? Because fracture is quite proximal here.
Yes.
And there is also a track of the previous nails removed. You can see that. Posterior approach. Posterior approach, can you go that much far proximal? प्लेट निकाल के नेल डालो. प्लेट तो नहीं निकल रही है, वहां तो अटके हैं सर. दो सर्जन तो अटके हैं, आप कैसे रिमूव करोगे? प्लेट नहीं निकल रही है. प्लेट निकलने जाने में तो ये इंजरी हुई है. अच्छा वो अभी आपने देखा? नहीं, प्लेट निकालने के बाद पेशेंट was shifted to the room and he complained of the pain because patient was explained in the operation theater relatives it is not removable, it may damage further more. They tried a lot.
So you are saying first my question is that how many screws are really has gone into the full bending?
He could not remove any screw.
He was not able. And the second surgeon has tried to remove any screw or not.
He must have tried, that's why it is fractured.
All the screws one after the other,
Yeah.
all have gone in the cold welding.
He may have tried.
Now the chance is that
Now
you
this is
cut-
the
you-
condition.
You cut the plate between the screws by a sharp cutter.
You cut the
Uh,
plate.
You can cut it. I have cut it so many times. And you can rotate it easily one by one to take it out. This is one way. And I have taken out one of the such welded plate of a daughter of a high court judge just 4-5 years back. She was back from Delhi after failing of the surgery. I cut the plate at number of places and removed it.
How will you
By
cut the
rotating.
plate?
By the sharp cutter. Just you take the cutter and cut it down. And it can be done easily.
So you will expose complete humerus on the
Definitely.
anterolateral
You
side.
just try it and you will come with taking out this plate. And give me a chance, I will take it out.
Okay, so that is the one aspect of the destructive surgery. One aspect of the destructive surgery. That is a possibility. Yes, that is also a possibility. But what can be the another possibility that we are looking for? Long pillows, yes, that can be done. But if you see there are lower down, there is not much space.
But in the locking plates, अगर 3 screws हमें मिल जाते हैं, fixation may be sufficient, and we can add with little bone graft over the fracture side. That's fracture side.
Okay. This plate is anterolateral, sir. You can go how far proximally you can go posteriorly, sir? How many times you have done the proximal humerus posteriorly? Practically, telling something is different. Doing something, it's different. Retrograde nailing, कहाँ से sir? Good. हो सकता है.
Can we fix the external?
Anybody wants to volunteer? Any
Sir, external fixator?
except remove cutting the plate, sir.
External fixator.
If you don't want to take the plate, 1 minute. There is any problem? If you don't want to cut the plate and if you want to fix that fracture, the option is that there are you can't put the nail. Tens can be accommodated to 2 tens from the top of the humerus, but the plating can be contemplated from posterior side easily. It's only an experienced surgeon can do it easily without damaging the nerve. And I have done it so many times. That's why I'm telling you.
Okay, fantastic, sir. So there was one option which everybody forgot.
Doctor.
We did a MIPO with the flexible. Oh, you wanted to try. So I opened up the paper.
Yeah. It's possible to remove the plate if you are having adequate number of gadgets available with you.
Right.
Secondly, you can destroy.
How will you remove the screws?
You can destroy the head of the screw.
Yes. Then
Can you the reverse tap? Sometimes it's possible to take it out. If not possible, destroy the head completely, remove the plate outside. Now you are left behind with the stump of the screw, which can be removed either with a reverse tap, or one can cut a core around it to remove the screw all around it. But same time you are getting
if
a
you
big
see the screws are very near now, if you try to cut the core and you do a hollow mill, what will the position of the humerus then?
whatever position is possible to remove.
Really, these screws are very near. If you see, if you try to remove,
It's possible.
it's possible.
Yeah.
But there is also a possibility of further damage.
Yeah, definitely that
2
cannot
times
be
it
ruled
has been tried. You are the third surgeon, sir. You are the third surgeon, and patient has come to you because you are the senior most surgeon in the city.
out. I can.
Okay, fine. So the option we had,
Plate on plate.
we
plate
did
on
a
plate
flexible nailing and the anterior MIPO plate, nothing to open. Anteriorly, the proximal, you can see the wound proximally and distally. Do you have that marker here? On that side, there was a marker there. This marker is not working. Yeah, working. This was the incision here, and second incision was here. And the plate was slit, long plate, very, very long plate. And that has further given a good function and the result. So this is the possibility of MIPO plating. And this technique, you can see here, function. And this is the paper, scientific paper technique, which changed my practice. It may change your practice. This is an optional way of tackling the humerus. These are the variety of fractures. We usually go for open reduction and internal fixation, plating, integrate interlock intermetal nailing, integrate retro-enders of flexible nailing. But why we are searching for options? Because if you search the literature, the problem is the wrist drop, radial nerve palsy. Problem is the rate of radial nerve injury, non-union, soft tissue, time of surgery, vascular admits. So this is the paper. In 2016, you can see complications are increasing. This is the first paper came on the cadaver, whether there is a possibility of minimally invasive plate osteosynthesis on the humeral stuff. And this was a cadaveric study. And what is the possibility of injuring the nerve when putting the screw by MIPO anteriorly? This was studied by this gentleman. And this is the real anatomy here, and this is the incision. This is the one case, extended indication, lower third fracture. Can it be done MIPO with the anterior plate? Yes, this can also be done MIPO if you have a place for 2 or 3 screws lower down. But the problem we found in this case was difficulty in keeping it reduced. You require one more assistant to keep it reduced. That was the problem. So one method has been described in the literature. Possible solution is external fixator. You hold with the external fixator or with the locking sleeves. Then you will not require one more assistant to get the reduction maintained while you are sliding the plate and keeping that. What we found that in such cases with the polytrauma expected problem, proximal fracture, stability is a problem. Many times you need to augmentation, only plate will not work. So what we tried is, we tried the flexible nails from the lateral condyle of the humerus. It is a very good stability here in the lateral condyle of the humerus. And that gives the stability further. You can see these incisions and the flexible nails along with the anterior plate, where you can put only 2 screws above and 2 screws below. And that gives a good fixation. It's a combination of relative stability. And ultimately patient is happy. So these may change our practice, certain techniques which are published very well in the literature. Another example, fracture lower and the dislocation, both. This can also be treated with the anterior breech plate, and this can also give a good result with a minimally invasive way. Middle shaft, this can also be treated with the flexible nails and the plate along with the MIPO plate, and that will also give a good function because you are not disturbing the rotator cuff by doing antegrade nailing or anything. And you are not disturbing distally also because you are going through the lateral condyle. This is the possible value addition. Another fracture where lower third with the butterfly. Here you have to dissect out everything, but without dissecting out anything, you can go with this method and you can have a good function with the fixation. But the second problem came later on when we did a lot of this type of plating. When we tried to remove it safely, it was a problem because removal was much more difficult than insertion, because there are the holes in between, and there the soft tissue adhesions becomes in the empty holes, and these soft tissue holes does not allow to get removed MIPO. So removal is blunt, cannot be possible blunt and blind. You have to see and sharply cut and open, then and then you can do the removal. So what we thought, tried to innovate in such situation, that why not to have a special plate for the MIPO where there are holes only in the proximal part and the distal part, and a single hole where you can adjust any angle of the screw here. And you do not have a soft tissue addition in between because that part remains smooth. So there is no additions in the holes in between. So removal will become less difficult. We are trying this biomechanically. We are under trial. We are testing it. This is the literature, recent literature of effects of the different surgical techniques on the mid-distal humerus vascularity, open reduction and internal fixation versus minimally invasive plate osteosynthesis. They have done a vascular study. This gives least vascular damage. And there are also studies of comparing the meta-analysis of 3 different surgical procedures. That is intramedullary nailing, open reduction and posterior plating, and MIPO, where they found a conclusion that the current evidence indicate that the MIPO is the optimal choice in the treatment of the humeral shaft fracture, and that open reduction plate osteosynthesis is superior to intramedullary nail. So they have compared all 3 in the meta-analysis. So surgeon has to balance between the reduce the risk plate failure and at the same time must have a biological optimal interfragmentary movement to get the callus. So we must think in terms of the nature, where the bamboos are flexible, are having a height, but still they are stable. So nature has devised this flexible yet stable. So we need a stable but flexible fixation. And this is the paper. Again, I have an appeal to all those who are not the IO members. Please become the IO member. And we welcome you at Amritsar. Please come to the Amritsar for IOCON 2022. Thank you.
One question from my side. That while you are doing MIPO anteriorly, and as far as the comminuted fracture is concerned, the biomechanical principles and the transverse fracture single, the biomechanical principles are different. The biomechanical principle which allows that one should apply the plate as a neutralizer from the posterior side, because that is a tensile surface, and the biceps creates the compressible area anteriorly, and if the fracture is comminuted, it's okay, you can go far. because no compression area or surface at the fracture site is created anteriorly in the comminuted fracture. But in the transverse fracture, it is created anteriorly and causing the convexity leading to the flexibility anteriorly. And this is a one paper that has been referred in the Rockwood Green. And recently I have gone through that. That's why the transverse fracture better should be done from the tensile area from posterior side. The nipple, if you are found of that, that should be also from posterior side, if possible. So ideally, it violates
So
the
you
principle.
use-
1 minute. It
This is
violates the
also, may I
principle of
request you
compressile and
to be
tensile
brief?
area once you are going anteriorly in a transverse fracture by MIPO. And if it is a comminuted fracture, it's all right. You can go ahead without violating the principles of AO. And that's what I have read in the Rockwood Green that I am just telling.
So you are advising MIPO by posterior approach.
No, just I am advising in the transverse fracture, you go posteriorly. Don't go for the MIPO, you go for
That
the
is
LCP.
also possibility. This
Yes.
is one of the options.
And that
It
is
is
also
not
easy
the
to take
only
it out.
option. This is one of the possibilities.
Yes. It's a weak.
Dr. Srivastava, please discuss later
Yeah,
because we
yeah.
are running short of time.
No, better.
Thank you, sir.
Thank you, sir.
And I will request Dr. Naveen and Dr. Anu to please come on the stage to receive their mementos. And I will request Professor N. Verma sir to give the memento to Dr. Naveen Thakkar.
May I request Professor Ian Verma, sir, to present the memento to Dr. Naveen Thakkar, the Secretary General of Indian Orthopedic Association. Thank you, sir.
Dr. Anu, please. Dr. Anu Agrawal. May I request Dr. Kapil and Dr. DC Srivastava to please give mementos to our respected chairpersons. Dr. Anu, please come.
Dear Chairperson. May I request Dr. Kaushal Agarwal to please present the memento to Dr. Anup Agarwal. Please.
We have a short tea break after this of 10 minutes in the Shushruth Hall. I will request all the respected faculty delegates to have a tea break and please assemble just after 10 minutes because we are already running short of time. Shushruth Hall, Shushruth Hall. It's on the, we are in the -1 and it's on the ground floor.
कोई करो दूसरा मैं दूसरा दूंगा
Hello. Good evening, respected seniors and faculty members. We are on the fourth session. For this, I will request Professor D.C. Srivastav, Dr. Tribhuvan Singh, and Dr. Anuj Gupta, and Dr. Rajendra Nath. Sir. Dr. Rajendra Nath, sir. I will request Dr. Amit Ajgaonkar. So, first, I will request Dr. Ram Prabhu to present his talk on plating in complex fracture proximal humerus.
मेरे हाथ में जरा भेजिएगा फॉरवर्ड करने का माइक टॉक वोट करो डॉक्टर राम Good evening, everyone. Respected chairman, co-chairman, my senior colleagues, and my friends. At the outset, I must thank the organizing team and especially Dr. K.D. Tripathi and the whole Prayagraj orthopedic fraternity who have invited me to this prestigious Platescon. Incidentally, this is the first Platescon that I am attending. It is a Platescon or a Platescon? Platescon, okay. So second Platescon that I am attending, and it gives me great pleasure to talk about the complex humeral fracture, and I'm going to talk about some basics and the principles about it, not many cases though. So, yeah. So we know that in the upper torso, shoulder is perhaps one of the most important joint to do activities of daily living. And in Indian scenario, it is also important for the toilet activities. And of course, in the sports, you know that it has immense importance, and it is important that it has to have a proper range of motion and practically the whole function which needs to be restored in traumatized shoulder. So we have in principles of open reduction, the most important part is the hardware. So in lock plates, it's which company which we are using this plate, the length of the plate depending on the fracture geometry, which screws, whether it is lock screws or unlock screws or compression screws, whatever that we use, where and how it has to be used, the proximal part and the distal part, number of screws, which are also important, and spacing between the screws are important, and again the length of the screw. All these parts are extremely important. We know also in the nail which nails and which generation that nails we use. We are not going to talk about nails today. And it is also important that what approaches we take to approach these fractures and how best we can expose those fractures to manage. And in case we do a proper preoperative planning and we actually think about all these aspects, we can avoid all the implant related complications. And this is what is extremely important, especially in the upper end of the humerus. And we see many complications related to not only implants, the approach, and also how the screws, etc., are placed. So Take for example, this is a 45-year-old male who came with a road traffic accident. He had AO type 11C3 anterior fracture dislocation. Now, looking at it, it is a gross fracture which is communicated, and many different thinking people will have different ways to manage this. But when we are going to fix this, we have to take all these factors into account, and this is how it has been fixed. Now, if you closely see that there are certain things which are done very well in this case, we can see that I think it's not moving in front. Where do I move? So we can see that from the tip of the greater tuberosity to the upper end of the plate, we can see the distance is about 8 millimeter, which is generally optimal distance that we must have. Then we can see the axial alignment of this. We can also see that the angle, which is fixed, that there is no varus. This is very important. So most of the aspects have been taken care of. But if you minutely see this, it is not moving in front. So you can see that there is a small gap on the medial aspect, and whether this gap is going to cause any problem or it is not going to cause any problem. So this is a cause of concern, okay, when we fix this. So when we sort of sat over it, continued the treatment, and we realized that next 6 months this fracture healed. So many times such small maybe errors can be taken care by the nature itself if we keep the geometry or biology well. Not moving. Okay. So this patient had very good range of motion, and if you look at the constant score, it was almost 87 at the end of 6 months. So that is a good result looking at the pre-op X-ray of this patient. Our own Gavaskar et al. Had done a wonderful paper in the second generation lock plating in the complex humeral fracture, and he gave certain guidelines and he gave certain tips to how to approach this. So he said that he and his friends or his colleagues said that 7 locking head screws are very important in such complex fractures, which should include 2 calcar screws. And the calcar screws placement are also important. Will be talking about it. They have to be augmented with the traction sutures from the rotator cuff, and those muscles have to be sutured there. Comminuted medial calcar, if it is there, endosteal fibular strut has to be used. And if there is a subchondral metaphyseal bone loss, you fill it with the injectable calcium phosphate cement. So all these are extremely important tips to manage this complex fracture. And if we follow this very well, I don't think, or we should minimize the complications that we have. So this is what they had shown, and this is what the strut which they did, the fibular strut graft, and this is how the sutures which were put on the rotator cuff, so that there was no flying off of the greater tuberosity or lesser tuberosity. So the principle of open reduction, as I told you, involves the implant, and it also involves the technique. So at the same time, it is software as good as hardware, which is also important. The getting stable reduction is at most important, just like any other fracture. So anatomical reduction is extremely important. Same time, it is not possible that to have an anatomical reduction. So in case of osteoporosis, the stability can be improved by reduction, strut grafts, purchase of the hardware, and preventing the flying off of tuberosity. That this is again important. That not only gives you the vascularity, but also maintains the stability. So there is a torus concept in which you see the greater tuberosity, the lesser tuberosity, the head, which needs to be properly aligned. And this illustration will tell you how that needs to be aligned well. So if you see the head of the humerus, which is supported by 3-legged stool, and this is the concept that all of you must remember. There is these are 3 legs of the stool, and they have to be, the fracture reduction can be done using the spikes, K-wires, and using those things as joysticking. The K-wires can be put in the fracture fragments, and you can joystick them to get proper alignment. And this is how this fracture or a dislocation could be reduced, and we can then start putting the plate on it. So sometimes there is a head split, and these are one of the most complex fractures, which also can be
managed or reconstructed using this principle. So if there is a comminution, there is a displacement, angulation of the main fragment, and the tuberosities are also flown off. So there is an excellent paper on this, which actually classifies this head split fracture into type 1, 2, 3, 4, depending on the severity and the complexity of these types. And we can see that there are fragments, the anterior type, the type 2, which is posterior, both the columns are fractured, and this is a very badly comminuted. So this is how those classification is done by that paper. Then, okay, if there is a head split, they have to be reduced well. And this is very important and quite technically challenging in most of the cases. So you can see in this, not only the head needs to be reduced, but all these three legs of the stool has to be constructed very well. So in a 4-part fracture, restore the medial hinge first. And this is perhaps the very important step, and this is what you have to concentrate on. And once that is done, you may not have a proper ankle or a varus, which has to be prevented, but then we have to restore the medial hinge through the rotatory interval, and then you approach the anterior and the lateral hinge. So restore the medial hinge, and then temporary K-wires have to be passed, and then again you can reconstruct the lateral and the cortex. So this is how we have to take those steps in order to get those fragments properly fixed. And this is what the K-wires which will be kept till your final plate has to be again put. Okay. So again, I'm emphasizing the fact that the spikes and the K-wires have to be used to get the reduction, and the lifting of the head also could be done with these K-wires. We should use a thicker K-wire just to restore this, about 2.5 to 3 millimeter in diameter. And that will not sort of gouge the soft bone or cancellous bone on this. This is how these fragments are fixed well. And then we come to the rotator cuff, because that has to be stabilized by suture. So we have to put those teeth, we can use Ethibond, or we can use Ethilon also, non-absorbable, and get those sutures down. And there is a method that before your plates have been put, you go through the sutures, get those rotator cuff, and then go through the plate, and then put the plate on the top of that. So that is important, that proper tension has to be properly applied, and at the same time they have to be fixed well. And this is a little technically difficult part which all of us have to learn. Once the tuberosities are pulled down, the sutures can be passed through the head as well as the shaft, and that has to be tied. So many times you will not be able to get accurate anatomical reduction, but you will be able to get a certain good amount of reduction which can give rise to fracture healing. So this is how the reduction may be maintained by 1 or 2 K-wires before you actually start doing plates. So this is the plate which all of you know about it. And then those screws have to be passed once those sutures are passed to the head. And there are special small holes which are provided for in these plates. First and foremost, before this, we have to have a proper positioning of the patient on the table. Many of us use beach chair position, which is very comfortable. The C-arm has to be on the opposite side of the operation table, and the patient's head has to be also shifted. So, sorry. And then we take the incision. All of us know about the deltopectoral incision. And this is how we palpate the coracoid process. We know, I think it's going in front. We see the sulcus, and we see the cephalic vein, which is kind of a landmark. Biceps becomes a lighthouse of the shoulder, and medially there is a lesser tuberosity, laterally there is a greater tuberosity. This is how we see that. And then we go through the internervous plane. We have to take care of the axillary nerve, which is on the distal part of the incision. and also medial and the lateral pectoral nerves. Of course, most of us will not injure them because we know the anatomy pretty well. So there are certain drawbacks because greater tuberosity goes on the posterior aspect in most of the cases. And that has to be approached. The access is a little difficult. And that's the reason why we have to actually have a good retraction. We have to use the spike, retract the deltoid very well in order to get to the posterior aspect, get the greater tuberosity anteriorly, and then only put the plate. So this is how the fracture fixation should be started. I am again emphasizing on using the K-wires to have a joysticking. So this is the angular stability which is afforded by the proper locking screws on the upper aspect of the plate. And the plate positioning is also extremely important, that there should not be a restriction of movements, range of motion to the shoulder, but the plate should not abut against the acromial joint. And the optimal direction of the screws are extremely important. The calcar screws, and they have to be well contained within the confines of the bone. So this is how we position the plate by passing one K-wire, see the greater tuberosity, take about 8 millimeter distance from it, and the plate needs to be properly put there. And then these are the sutures which have to be put. And again, the distance between the tip of the greater tuberosity and the plate should be about 8 millimeter. It should be caudal to the tip, and it should be 10 millimeter dorsal or on the lateral side. This is how on the lateral aspect we can see. This is the proper positioning of the plate on the AP and lateral. And then in the axial section, this is how the plate needs to be positioned, about 8 to 10 millimeter lateral to the bicipital groove. The screws again, if non-lock screws are inserted here, the reduction will be lost. You remember that they have to be lock screws on the upper end of the humerus and the plate. The screws have to be approximately the number generally are along with the 2 calcar screws. 7 screws have to be used. The length have to be appropriate, that it should not penetrate the cortex and it should not go in the joint. And then the purchase at the end of it should be optimal. We have to really have a feel that it is holding well, and distally avoid secondary displacement, which can happen, which can again give rise to some kind of varus or valgus. We have to be a little careful about it. Again, the number depends on the fracture geometry, how distally that fracture has gone. So we have to depending on that, the length of the plate and the number of screws up. And we have to avoid the stress riser. So to summarize, these are the principles of open reduction internal fixation that we should know. Good imaging and preoperative planning is extremely important. Patient position, we can use beach chair or a supine position depending on what you're comfortable with. Then anatomical reduction and stable reduction is very important. Sometimes in the comminution we have to dock, especially on the medial side. The tuberosity have to be reduced well, and we have to prevent the flying off of this tuberosity by the pull of the rotator cuffs. The implant choice, depending on what you want to use, which company, etc. There is hardly any difference between the titanium and stainless steel, but somebody has a preference because if you have to take some scans or MRI later on, titanium is preferred. The medial calcar screw is extremely important, and that has to be placed very well. Augmentation with a fibular graft on the medial side. Again, if there is a comminution or if there is instability, and we have to augment with the bone graft as Dr. Gavaskar's paper has told you. And post-operative protocol of pendulum exercises, slow range of motion exercises, and later on strengthening is important. So generally with this, in about 6 to 12 weeks, we should be able to get almost 75 to 80% of the movement. And by 3 to 4 months, patient should be able to regain most of the movements, and the fracture should join by then. Thank you very much. Questions? Up to which place? You mean the upper end of the humerus or lower?
Like this.
It has to be subchondral. It has to reach subchondral level. And you have to see in different direction that it has not penetrated. That is very important. Because many times there is a little bit of collapse which occurs. So it needs to be at least 4 millimeter away from the.
Yeah, in one of the conference, I heard somebody from outside that the length should be lesser because
Yeah.
it doesn't hold the, it should not go up to the bone. It holds like a hollow cup
Yeah.
and in different
So
direction.
it's like in different direction the screws are that actually holds the whole head. So you don't have to penetrate. So it has to be 4 millimeters distal to the articular edge of the humeral head. Yes, Amit?
Sir, in those canals, intramedullary canals, which are very big, we put the fibula, or it is said that you may use a tricortical strut graft also. So what is your preference and to make the fracture more stable and to hold the reduction into valgus, especially in those varus impacted fractures?
So I think fibular strut graft is a good idea, though in primary cases I have not used. I have not used fibular graft, but I think that seems to be a better idea than the cortical bone.
So in varus impacted fractures, if once you reduce the fracture in valgus, then the medial crushing of bone occurs. No?
Yes.
Then it can go into varus failures again.
Absolutely, yeah.
Post-operatively, So then how do you avoid those?
Yes, so in such cases, the fibular graft is a good idea. Exactly.
Okay.
So we have to prevent the virus. You questioned and answered yourselves. Yes, sir.
When you apply that plate, which screw you will put first?
The
You
head
reduce
screws.
with the K wires. Which screw you want to put first?
So in the head, sir, the proximal locking screws I'll be
You don't
using.
want to buttress that, put that cortical screw first?
You mean the distally?
Yeah.
No.
Because that is what is been advised that you.
Yeah,
buttress
so
and put
there
a
are
cortical
different
screw.
ways of approaching that.
Yes.
But you asked me what I would do.
Yeah,
so
okay.
that would be.
What you mention is, first put the screws in the head. And the plate, if it is remaining slightly away distally,
Yes.
now you buttress it, you will automatically get a
Valgus.
valgus. But if you put first into the distal part, you won't get that.
No, but if you tighten the lower screws, you mean to say the shaft should be lateralized?
You have put the screws into the head and the plate is lying slightly
Yeah. So, I mean,
slightly away.
you saw the X-rays and the plate, which is always about 10 degrees valgus. It is away
So
from the
once you
humerus.
put the plate down,
Yeah.
automatically the head goes up. It's
There
the
is-
same thing which we do for distal areas.
Yes.
So, but instead of locking the, sorry.
Why did I ask the question, Dr. Ramas? Your diagram showed first the screw in the cortical screw first in the diagram. But you said at first, that is why.
No, but even if you put the cortical screw down, you do not tighten it completely. You put it in the oblong hole so that you can get it up and down. You do not tighten it. And then you put the upper screws.
I can answer your fibula question. I have done sufficient fibula, at least 20 about so. And I feel it's a wonderful operation. If there is a medial comminution, you really find it out by a CT scan if you need. And unless you put that medial fibula, or even you can, if you don't want to take out a fibula, you can put in the allograft of a
Corticocancellous.
any of the corticocancellous there. Or you can put in a plate. You can put in a medial plate, intraosseous plate, intramedullary plate.
Sir,
but
sir,
how many?
Tanna sir, so have you done that in a primary case or in a revision case?
It is
that?
in primary case. In a revision, almost always you need
Yeah,
it.
exactly. So
but in a
revision-
primary with the medial comminution,
Yeah.
you need that.
Sir, but the plate, you're talking about the plate. But I don't know, have anyone of us done platings? Intramedullary plate.
I've done it on 2 or 3 occasions. Only thing is, if ever the fracture heals up an infection, it's damn difficult to heal up.
Another thing, another thing, the fibula. Fibula is excellent. No, I have also done fibula, but then I always do those tricortical struts. Take them and put them back into the medullary canal. And then they're really good because they have soft bone also to act as bone graft.
The Tata bone, which you and me get it in Bombay, it doesn't really act as a solid strut. So I think the fibula, it gives you that once you put in the fibula, put medullary canal and shove it up. And once you shoved it up on the medial side, now you have a perfect fixation there, and that itself adds up to the fixation. It adds up to the fixation. It's a second implant it becomes.
But then the fibula, exactly, it should abut on the lateral cortex, and then the other tip should go on the medial side, holding your head in. And the Tata, I have not used the Tata, I use autogenous graft from the patient, tricortical strut. I take it and put it inside the intramedullary canal.
Sir, we do a different technique. No bone graft, only flexible nail from the lateral condyle, and that will give a medial support and additional plate. So, yeah, Ahmedabad.
Not Chandak. This is Ahmedabad ka tera. ठीक है.
Thank you, Dr. Ram Prabhu. Next speaker is Dr. Amit Asgavkar. He will be speaking on recent advances in the management of intercondylar fracture elbow.
सर जो गए सर उनके बारे में
Everyone has been doing this surgery. There's nothing new in this surgery. But let us see, since we are talking about platings, this is one of the hot topics in the upper extremity. आगे नहीं जा. एक मिनट. हाँ. नहीं. अच्छा, ओके, बाप रे, इतना सा. ओके. क्या हुआ? ये नहीं हो, आगे नहीं जा रहे. गया? हाँ. क्या बीच में? अच्छा, okay. We know that these are the approaches. Now, olecranon osteotomy, what I would like to talk about is, whenever you're doing a fracture of an intra-articular distal humerus, why are we creating another intra-articular fracture in the olecranon, which is equally important? Whenever we do this distal humerus fractures, around 70% of the times the distal humerus heals, but the olecranon osteotomy is not satisfied because we are tired at the end of the surgery probably, and the olecranon osteotomy we take it very. So what is my convention is, why not do an extra articular osteotomy? An extra articular osteotomy for the fractures of C1 types, wherein it's not needed that you do an intra-articular osteotomy to see the whole of the distal humerus. So it's a perfect articular restoration that we want. It's the pillar height and the anatomy that should be restored. Olecranon and the coronoid foci should be created properly, and the immediate post-operative mobilization which is required. We need the restoration of anatomy of the trochlea, capitulum, olecranon, coronoid, and the radial head. And a stable fixation of your osteotomy. That is very important. We really forget, or we take it very lightly, the olecranon osteotomy. So we need a stable fixation of the osteotomy. Yeah. So we know that this is the incision. It's a curvilinear incision over the distal humerus. And yeah, आगे नहीं जा रहा है बराबर. You have to first isolate your ulnar nerve. Once the ulnar nerve is isolated, this, now look, in this, This is the extra articular osteotomy, which I would like to show you. This is the way you should know the opposite point. Where is your opposite point? And accordingly, you just do a shave off the olecranon. Just shave it. So that along with the olecranon, the whole triceps mechanism comes out. Yeah, so now that whole triceps along with that olecranon, look, the whole of the intra-articular olecranon is remaining, and you can see the fracture very well. Temporarily, you should hold the fracture fragments, the intra-articular fragments, by towel clips or ball spikes or a patella holding forceps, whatever you have. Get a reduction. Most of the times, the reduction is very easy to attain, unless and until there is a lot of comminution. Once you do that, put temporary holding K wires, or you can have those wires for putting cannulated cancellous screws, or lateromedial screws should be put. Here, it is held and you can see this. The final intracondylar screw is put, and after the intercondylar screw, you can see the olecranon. The whole of the olecranon is seen here, and you can very well see the joint line also, as well as the fracture. So instead of creating another intra-articular fracture, why not just do an extra-articular osteotomy and do this fixation? Here you have done this. For more exposure, definitely, when there is a lot of comminution, you have to do an intra-articular olecranon osteotomy. No question about it. Now the plate is applied, the posterolateral plate, the medial plate, and finally you do this, you get a good reduction. Generally, the upper fragments at the supracondylar level, there is not much to do, and you get a good reduction. It's like solving a jigsaw puzzle, and there you close the osteotomy. But closure of the osteotomy is also very important by the TBW. After closure of the osteotomy, you get this. This is you have to try your movement. We should try and get full movements after closure of the osteotomy, and should see to it that the osteotomy does not open. This is the post-operative picture in the OT. And another example I'll show you. This is of an extra-articular osteotomy. It is more or less the same. After isolation of the ulnar, now there's an extra-articular osteotomy which is done for a C2 type of a fracture. And there, the whole thing is exposed. You have to slowly dissect down the triceps, and that's the way you have to release both the medial and the lateral sides, and the whole triceps should be lifted away, which is very easy to do, and preserve the bone inside there, and put the plate. You have to know that you have got just a thin margin of bone to work on, the intercondylar space. So that margin of bone, you have to put a good screw and in the proper plane. You have to restore your coronoid fossa as well as the olecranon fossa. There, that's a final X-ray once you've done it. And here, this you can see the plate, one plate, two plates, and the whole thing moving very well. And you've got a good reduction. That is the way you should get it. And immediate post-op, you should immediately mobilize the patient. Once you've got a good reduction, a good stable reduction, mobilization is very important. Do not keep the patient in slabs for a long time. And there, this is the fixation. And this is another case wherein we have done this orthogonal plate fixation. And this is the range of movements of the patient. Many a times, these patients land up with terminal range of movements which are restricted. You may not get full range of movements. This is another case wherein we went ahead and did this orthogonal fixation. And look, this is the way we have done it. And this is healed. Now O'Driscoll has designed a parallel plating, which is also very good. There is a lot of confusion whether we are doing an orthogonal 90-90 or a parallel plating. Now this parallel plating has got certain rules. We all know that each screw should go through a hole. Each hole should be screwed. All screws should be locking holes. And all screws from both the sides should be interdigitating screws. No screw should be passed from beyond the plate. All these are there are 7 rules for this parallel plating. But that is also simple, because many a times what we do is we want this parallel plating. It's like an arch. You compress, there is a good compression at the supracondylar level, and the arch is maintained by the keystones. Keystones are the intercondylar pieces of the bone. So this is the healed fracture at 3 months. So this is the parallel plating. This is the final outcome. And you may do a hybrid fixation. Sometimes we have to do hybrid fixation. Always we cannot follow it. You have to put screws from outside the plate. Sometimes it is not possible. So you have to put screws from outside the plate and get reductions. And this is the way it is done. What we want is stable, parallel plating gets a stable bridging and excellent securing of the fracture with angular stable locking screws. No primary and secondary loss of fixation due to stable plate screw connection, and all locking screws are used. It is especially used in lower fractures, reduced vascular periosteal damage beneath the plate, reduced screw loosening thanks to locking screws, no thread stripping. The only problem in parallel plating is we just elevate the whole of the periosteum on the lateral side. If you elevate from the lateral side, it is difficult because you have to have, there are certain arteries which supply the lateral condyle, and you can denude the lateral condyle. This is the pre-shaped plate, excellent distribution of forces around the screws, better placement of the plate and less tissue irritation. Optimizing buttressing avoids collapsing of the fragments. These are all the advantages. It has to be put in osteoporotic bones. It is used pre-contoured, saves the timing, and useful for short metaphyseal segments. Resists the varus collapse. Whereas in the orthogonal plating, you do not have a lateral buttress. You only have a medial buttress. Better preservation of the blood supply. Now you have a confusion whether to do a parallel or an orthogonal. Orthogonal is a workhorse. We all know how to do the orthogonal plating, the 90-90. But parallel plating also we have to learn. There are a lot of papers which have talked about confusing results. I'll show you. And this is the parallel plating. The arch has to be maintained. And these are the... There are these papers. 2 showed parallel plate fixation to be substantially more stable than the orthogonal plate. This was in 1994. Some showed in 1997 there was no difference. And some showed that all biomechanical studies failed to actually resemble the true clinical settings and difference in fixation. Again, there was a big confusion. Patients do well with both the platings. There's no question about it. You have to have a take-home message, wherein the take-home message has come finally after this paper 2011, again, which was confusing and there were controversies. And this was the one, latest 2019, where Wang and Louis have studied 305 patients and concluded that parallel plating was much, much superior to orthogonal plating, 90-90 plating for the distal humerus. Now, parallel plating was designed by O'Driscoll long time back, but he had designed only for non-unions, wherein he shortens the supracondylar bone, and then the coronoid fossa and the olecranon fossa are recreated by burrs. You compress the fracture of non-unions, but then now you can use in fresh fractures also, and this is a good study. Concluding, I would like to say that good exposure of the distal humerus is obtained by an olecranon osteotomy. Now, whatever osteotomy you do, whether an extra-articular or an intra-articular, if you are used to do an intra-articular, go ahead, do an intra-articular, but if at all you can try an extra-articular, do try it. Complete exposure of the distal articular surface of the distal humerus is possible by this approach, an olecranon osteotomy approach. It does not compromise the extensor mechanism of the elbow. Fixation may be a parallel plating or orthogonal plating. Again, it all depends upon your anatomy of the fracture and how your fracture is. If you anticipate varus reductions or varus malreductions, then you have to buttress both your pillars. So do a parallel plating. If you're okay with it, then go ahead and do an orthogonal plating. With proper precaution, ulnar neuritis, which is a common problem in these fixations, and non-union of the osteotomy, which is another common problem, can be avoided. Thank you.
Thank you, sir. So we cannot wait to hear Dr. D.D. Tanna, sir. The third lecture is from Dr. D.D. Tanna, sir. And then we can take the questions. The terrible triad around elbow, and then we can take all the questions.
ये चलता है ना भाई? हाय, ये चलेगा? Yeah. Can you start the presentation, please? Terrible triad. Basically, the terrible triad, unless and until you understand, you are going to mess it up. So understanding the terrible triad is first most important, and then executing it there. We all have done head excision of the radius in past. Nowadays, we hesitate. We say we'll do a replacement or a repair. Today, if it is repairable, you must repair. So when can you do an excision of the head without any problem? If I can ask you that, if you don't mind.
After removal, sometimes go to
No. Yes. If there is a dislocation,
yes,
you cannot excise the head of the radius.
yes.
So how will you confirm this head of the radius is not a part of a dislocation which is auto-reduced? Do you get what I'm saying?
Dislocation, maybe collateral ligaments already gone, then cannot excise the head
Yeah.
of the radius.
On the table, before removing the excision of the head, see first whether the elbow is stable or not. And in an isolated head of the radius fracture, there will not be huge swelling, and there will not be a ecchymosis medially. Because when there is an elbow dislocation, MCL also breaks down and you get an ecchymosis and a huge swelling. So before excising the head of the radius, as a definitive treatment, you confirm two things. There is no ecchymosis, and under anesthesia, it is still stable. Then go ahead and excise head of the radius. It will not have a problem. ये नहीं चलता है इधर से भी उसमें लगाया है क्या? तारा में लगा रश नहीं तो वीडियो वगैरह तो मारू होल प्रेजेंटेशन इज यूजलेस. नहीं ये वीडियो नहीं है, मगर आगे जाना मांगता है. वीडियो होता है इसमें, तो बहुत वीडियोस है. ले पेलू तारू छे पेलू. Any idea why, if I can come back to you, doctor, when you excise the head of the radius, when MCL and LCL are intact, and coronoid obviously is intact, there is no problem. Today, only report which has come is after 22 years, excised head of the radius shows some newborn formation which is asymptomatic.
And some people have said that there is going to be some ulnar variant, which is totally asymptomatic. You and me all have done head of the radius and we haven't regretted. But today's now, they talk about it, can't exercise the head of the radius. Either you have to repair or you have to replace. Excision head of the radius, you will have a full range of flexion, extension, supination, pronation. With the head of the radius, chances are 50% of the time you will get a good movement, which will not last you longer. And 50% of the time the movements are restricted. Split fracture, if you repair it, which is normal, which has to be repaired, they are the only ones which will get 100% movement permanently. When you are doing this terrible triad, we're talking about the head of the radius, coronoid, LCL, and MCL. All four ligaments, where all four things have been ruptured, then it is known as the terrible triad. Unless all four of them are repaired, it will be stable. That is also not true. Because if I can say elbow dislocation with only the ligaments gone but no bone injury, you reduce it, it is stable 98% of the time. There are now say 2%, 3% of the time it may be unstable. They are the elbows which we immobilize for a short time and then start movement. So the stability is mainly from the bony structures, because in a non-fracture situation, there is a good stability. The bones have not fractured, and that's the reason it is stable. So if you reconstruct the normal bone, that means the head of the radius, which is normal length and normal size, which can only be possible in a split fracture or in a two-part fracture. In a three-part fracture, most of the time it is possible. But in a replacement, length of the head of the radius, width of the head of the radius, all this may not be possible. That's the reason why we have to go down and do the LCL, MCL, coronoid, and everything. So if you can reconstruct the bone, it should be stable, because unfractured elbow dislocations are stable.
In a terrible triad, when should we exercise? In a terrible triad, when should we or we should not?
No, I think in a terrible triad, from the stage, I will say you should never exercise.
Yeah, but you do.
Okay, I think since you know it, I'll talk about it. The time when the head of the radius were not very good, they were not available of all sizes. I applied the principle. If the MCL is intact, head of the radius can be excised without any problem. So you know that article which I have written there, I excised about 11 of them at that time. I excised it purposely and went back to the MCL and sutured the anterior fibers of the MCL, which is the most important, and then a lateral fibers of the MCL. And elbow was stable. Probably one of the case I'll be showing it here. This is what I did it. And as I said, unofficially, since he has asked me, I will talk about it today. That is not, it is what I have done it. I have got away with it. And I have also done it for quite a few of my other students. But officially, I can't talk about it because I am talking about only 12 cases or so. Sorry?
Parop, how do we check whether MCL is ruptured or not before we put something for?
Good question. The statistics are, if the elbow is dislocated, MCL is gone. Some people believe that MCL may not have gone. But in the reconstruction, MCL is the last one you need to repair. You don't need to repair all the time. LCL is the most important ligament which you need to repair almost all the time.
MCL fails last in a posterolateral instability. It fails last after the LUCL.
It is a ring concept. If you and me are talking the same language, it's a ring concept. If the head of the radius is displaced, it cannot displace unless the MCL is gone. If the head of the radius is not crushed or displaced, then MCL will be intact. Okay, now here there are These are the structures which are MCL, LCL, head of the radius, and coronoid. If 4 of them are intact, elbow is stable. These are the 4. Now, as I mentioned, if ligaments and muscle rupture, but the bones are intact, elbow is stable after reduction most of the often, that is 98%. And it only needs a temporary pain restriction, and then immobilization is generally not required. We start mobilizing almost immediately. This is where this is where we see. These are the current thoughts are, even in these elbows, after 10 days, you find out that elbow is still stable, and then only proceed further. Otherwise, this may need a suturing of the ligaments at times. Now here, if the head of the radius is fractured and MCL is intact, as you can see here, MCL is intact, then we can excise the head of the radius without any major problem. This is what I talked to you just now. Now, if the head of the radius is fractured and MCL is gone, if you excise the head of the radius, it is unstable. So head of the radius either has to be repaired or it has to be replaced. Then only it will be stable. You may not do and need anything to MCL if the head of the radius has been perfectly put in with the same length as it was originally lying, which is a hit and a miss situation in a replacement. Now, radial head and coronoid, they are both fractures. Generally, the MCL and LCL both are gone. So you need to repair the head of the radius or replace, repair the coronoid, and invariably repair the LCL. After that, you decide whether MCL needs any repair or no. Then you repair MCL. MCL is not always needs repair. I'll come to those cases. Now here it is. This is what I was talking. This is the one where you see so much of a ecchymosis. This is 100% MCL is gone. If you see on the table, you will be able to see instability. And this is the head of the radius which has been dislocated, and that dislocation, who has that pointer? Sala mane nathi aapto. Thank you. Yeah. So if you see, no, I know. Now repair both, as I mentioned. Now, if you see here, this elbow is dislocated and auto-reduced. This is the time when the head of the radius, we miss it out as an isolated head of the radius. Now we all know with terrible triad, if all bony structures regain their length, then only the elbow becomes stable. Most of the time, almost all the time, the ligaments also need repair. Repair head of the radius, repair coronoid, and then check if stable. If not, suture LCL and check again. And the last, if required, suture MCL. Repaired bones with original structures give the maximum stability. Head of the radius fracture can be repaired if normal shape when there is a split fracture of the head, which is repairable, like this fracture, which is repairable. If it is a 3-part fracture with comminution, you can still repair them almost with the normal length. Now here, this is a beautiful article by Ring, Quaranto, and Jupiter. 13 of the 14 patients with meson type 3 comminuted fractures with more than 3 articular fragments, supination pronation will not be satisfactory if you repair. So if there are more than 3 fragments of the head of the radius, you should not make an attempt to repair, but it should be replaced. This is the article which talks about. Associated fracture dislocation of the elbow or forearm may also compromise the long-term results of the radial head repair. Our data suggests that open reduction and internal fixation is best reserved for minimally comminuted fractures of the head of the radius with 3 or fewer articular fragments. Now, this is the one which in our country we try to compromise, because even in a metro in city of Bombay, I do not get every time the best of heads available. They either have to get from Ahmedabad, from Calcutta, somewhere. So in interior, it may not be available. So in that situation, still you may have to compromise, which is still better. Even if it is 3-part, 4-part, you repair it. If you can repair it, it still will work and the elbow dislocation will be prevented. Now here is the fracture. You can see that complete dislocation, head of the radius, coronoid, everything is gone. CT scan confirms that. And you see now, I have replaced the head of the radius. After repairing the head of the radius, you assess the elbow is still unstable. So now coronoid was not there, so I repaired the LCL. Now this is what I am repairing, the LCL. This is the LCL with the anchor which has been put. LCL anchor. Where do you put it? If I can ask you, doctor, if you don't mind. Never use. Amit तेरे को ही पूछेगा. तू झूठा होएगा तो अर्थ नहीं. Where is the LCL anchor put?
I take the LCL along with the common extensors.
Sorry?
Along with the common extensors.
But where do you stitch the LCL on the humerus? Isometric point. Which is that? Pakada.
Lateral epicondyle.
No, pakada. Isometric point bolta hai. It has to be right into the center. What you say is right. What you say is right. So, like here, LCL stitch with an anchor. Now you can see this. This is not the isometric point. This is the isometric point. So this is where surgeon did the small mistake. Anyway, LCL was stitched and still there is a dislocation you can see. So now you'll have to go and do the MCL. So now surgeon went ahead, replaced LCL, repaired, and still you can see. And this testing has to be done from flexion to you have to go up to about 10 degrees of extension. If you remain so much, it will be stable. But if you go down, it will be unstable. So do not cheat yourself by only doing this. Unless anti-gravity, it goes to not 180, but 170, then it is unstable.
There was no anterior injury? Anterior.
No, there was no coronoid injury here. There was no coronoid injury.
Anterior capsule, it looks like.
No.
Going anteriorly.
Nothing was done to the coronoid, and this has become stable now, and this is what we left here.
It was a radial head piece.
Yeah,
Probably.
yeah.
Anterior capsule has to be.
No, there is a radial head piece anterior.
The capsule need to be repaired when there is a coronoid injury or there is an anterior instability. What you say is true. But in this situation, it was only the head of the radius which was dislocated with the elbow dislocation, and coronoid was not affected. What you mentioned is that but this is not a terrible triad. Terrible triad has to be coronoid, where you will have to repair. I'll come to that.